over to you, sir.
Hey, Chinmay, thanks a lot. Just a real sound check. Can everyone hear me?
Yes, we can hear you, sir.
Great. Okay. Well, thank you again for the invitation to be here. For me, it's a real pleasure. My first talk in India, I think, was 1997 or 1996 when I came to India to take my dad's ashes to Haridwar at the time. So it's been almost 30 years. So I feel like it's been maybe 4 or 5 generations of radiologists that I've been able to lecture to. So for me, it's a real privilege to be invited. And I think what REF has done over the last 25 years under yours and Akshay's, and especially Bhavan and Bijol's leadership is amazing. So, congratulations to everyone. So what I'm going to do, and I did tell Akshay that I do have a hard stop in an hour. Usually I can stay longer and answer any questions. So I do apologize for that. What we're going to do is talk about a simplified approach to craniofacial vascular malformations. And the challenge that we run into, and I've seen this over the last 30 years, is that what I refer to as the nomenclature nightmare. So when you are looking at these various vascular malformations, there's so many terms that have been used over the last, like I said, 30 years, even longer than that, and it still gets confused now. So you'll hear things like hemangioma, strawberry hemangioma, cavernous hemangioma, cystic hygroma, nevus flammus, so on and so forth. And the challenge that you get into is, where do I even start? It just gets really, really confusing about how to manage this. And so what I want to do is to give you, number one, a historical perspective, and then number two, an approach to all of these lesions, because they can be incredibly confusing. But on the other hand, I think if you have some type of construct, that's going to get you through 80% of the abnormalities. And the ones that you're not sure about, you can always, ask a friend. But I think if you take this approach, then this will get you through about 80%. So let me start back with a little bit of some of my history. Back when I did my residency at Harvard at the Brigham and Women's Hospital, right next to Brigham and Women's Hospital was Boston Children's Hospital. And in 1982, so I did overlap. I never had the privilege of meeting these people, but John Mulliken was a plastic and reconstructive surgeon, and Julie Glowacki was actually a pathologist at that time. And if you think things are confusing now, it was even more confusing back, if you will, in the last century. And what they did in this classic paper, which was hemangiomas and vascular malformations in infants and children, a classification based on endothelial characteristics, they were the first one to subdivide vascular lesions in the head and neck into vascular tumors and vascular malformations. And specifically in vascular tumors, the way they separated these out is that these specifically had endothelial proliferation. So the first bifurcation was the presence of endothelial proliferation. And at that time, this really was, I don't want to say necessarily revolutionary, but it really was a substantial moving forward into an understanding of these lesions. So if you want an example of what vascular tumors are with endothelial proliferation, these were divided into benign, such as hemangiomas, and that's what we're going to spend the majority of our time on, locally aggressive, and these are things such as Kaposi sarcoma, hemangioepitheliomas, and Kaposi's. We all know we saw a lot of this in actually the AIDS era. And then you have malignant lesions, including angiosarcomas. So the one thing that I do want to do is, again, as I kind of toggle between, different organizations I'm involved with, when we're talking about these vascular lesions in this context, realize that things like Kaposi sarcoma and angiosarcoma are felt to be, quote unquote, vascular tumors under a vascular malformation category. Now, if I was giving a talk on head and neck tumors, then all of a sudden, Kaposi sarcoma and angiosarcomas are actually WHO classified as tumors. So just realize that there is an overlap depending on the organization that you're working with. But in general, these lesions are classified as vascular lesions. They are vascular tumors, and they are part of the organization I'm going to mention in just a couple of minutes. Now, what about vascular malformations? Vascular malformations are divided into 4 areas. These are lymphatic, capillary, arterial, and venous. And what separates these out is that there is no endothelial proliferation. They're not necessarily static because these tend to grow as you get older. So they do expand, but they don't have the rapid endothelial proliferation that you'll see in vascular tumors. So why do I mention this? Well, what I'm going to do is over the next 15 minutes or so is try to give you a construct, or if you will, a simplified approach to these vascular lesions that will help you, I think, at least get through 80%. But when Mulligan and Glowacki first described this paper, what this ended up resulting in is an organization that's been around for probably about 20 years right now. It's called the International Society for the Study of Vascular Anomalies. And this is a separate organization. It's separate from the WHO. But what they do is they have a website and they look at all of these various vascular lesions, and they have associated various genetic malformations. They've subdivided these. They've actually identified all of the classifications. So if you really are, if you will, inspired by these vascular lesions like I am, I would encourage you to go to the website of the ISSVA. And occasionally I'll throw a couple of snippets out there, but if you really want the latest on every single lesion that's considered a vascular lesion, that's where I would suggest going to. So what we're going to spend the majority of our time is that we're going to talk about vascular tumors, and specifically, we're going to use our index of hemangiomas. Then we'll go and spend the rest of our time, and I'm going to give you my Olympic rings approach to vascular malformations. So let's go ahead and start off with hemangiomas. So when we start off with hemangiomas, there's actually two types of hemangiomas. There's the infantile type and the congenital type. The infantile type is much more common than the congenital type, and the infantile type is the one that's for diagnosed during the first year of life, and this is the one that has the rapid growth and then eventually involutes. So when we look at this diagram here, and this is from a nice article in Radiographics, the infantile hemangiomas are the ones that are present at birth. It has a proliferative phase, and then eventually it has an involuting phase. So when we specifically start talking about the imaging findings, we're really going to be focusing on these infantile hemangiomas. And I want to emphasize up front, you have to understand the imaging findings and the clinical presentations of hemangiomas, because if you do this, then the other malformations that we'll talk about later are going to fit very, very nicely. Now, we all know that there are various associations with other lesions when you have infantile hemangiomas. We all know about the face-associated syndromes, which are things like posterior fossa malformations, cardiovascular anomalies, eye anomalies, etc. I can defer you to other talks of the ISSVA for more information of this. And there's also other malformations, as you see here, this lumbar sacral plexus association syndrome. So the bottom line is that with infantile hemangiomas, the majority of these are sporadic and idiopathic, but on the other hand, there are some that are associated with other lesions. The other thing too is that sometimes clinically it can be challenging to determine whether it's infantile or congenital. What you end up looking for, the specific molecular marker, is the glucose transport protein. And if this GLUT receptor is positive, that indicates that the hemangioma is an infantile hemangioma. So we talked about infantile hemangiomas. Now let's talk about congenital hemangiomas. Now, congenital hemangiomas are the ones that are present at birth. So if you will, these are the ones that are present at birth, and then when you're born, you go ahead and see them. So when you look at these congenital hemangiomas, just realize that these are GLUT1 negative. So that's how you can molecularly separate infantile hemangiomas from congenital hemangiomas. Now, there are also these mutations, the GNA11 and GNAQ. Again, everything is now being associated with genetic malformations. Again, I cannot remember every single one because, based on my different talks and the pathologies I have to cover, I always have to go back to the books. But I do remember GLUT1, but just remember GNA11 and GNAQ. And again, you can go back to that website to figure that out. But what I do want to point out is that when you have congenital hemangiomas, these congenital hemangiomas, similar to infantile hemangiomas, can rapidly involute. So if you have a rapidly involuting congenital hemangiomas, this is called a rich. I love that name, rich. On the other hand, you can have hemangiomas that never involute and stay the same. And these are what are referred to as niche. These are non-involuting congenital hemangiomas. So obviously, if you have something that rapidly involutes and then doesn't involute, it only partially involutes, well, now you have a pitch. And that pitch is a partially involuting congenital hemangioma. So I think we all know about pitches because I happened to be in the West Indies a few months ago, so I was there for the cricket World Cup. So I've become a cricket fan. So I know in India we know in India we have the best cricket in the world, right, Chinmay? I think we can all agree on that. And the rest of the world knows that India has it. So that's the one way we can remember pitch, because that's the partially involuting congenital hemangioma. So let's go ahead and start with the imaging findings of hemangiomas. And these are extremely important because if you remember this, then everything else I would suggest is going to fall into place. So when we have hemangiomas, they are divided into a proliferative phase and then an involuting phase. So the hemangiomas clinically can present such as this. They can be clinically obvious and then present as a mass. So I would say the majority of time, the surgeons or the pediatricians can actually see these lesions, and sometimes they can and sometimes they cannot. But my point is that when you have these hemangiomas in the proliferative phase, they will present with a lobulated mass such as this. And the key thing here is notice how it's high T2 signal. And I want to emphasize that high T2 signal. You can see the lobulated appearance. And if you look real closely, especially on the non-contrast T1 weighted images, we can see these flow voids. So if you see these flow voids right here, that tells you that you're dealing, again, with a high flow lesion. And then when you give contrast, this thing homogeneously enhances. So you have two factors here that tell you have high flow. You have it on the diffuse enhancement and then also the flow voids. And then if you do perform ultrasound, you're going to see these prominent vessels. So this is the classic example of a hemangioma in a proliferative phase. Another example here, these are actually relatively common. And this is an example of a hemangioma involving the parotid gland. Now, sometimes radiographically, this can be confused, and some people may think that this is a parotid tumor. Some people may think it's a rhabdomyosarcoma because that is the most common solid tumor in a child. But when you look real closely, you can see that there's replacement of the parotid gland, P parotid gland. There's high T2 signal, and you can see this large flow void right here, this very large flow void. When we look at the non-contrast T1 weighted image, we can see that flow void. And when we give contrast, we can see diffuse enhancement of that parotid tumor. So when we see this mass, this is a hemangioma in the proliferative phase. Now, if you are confused, so if you don't see a lot of this, now, with me, I've seen enough of these where I feel fairly comfortable making the diagnosis on imaging. But if you're not sure, ask the referring physician to correlate with their physical examination. Because if you actually look at the subcutaneous fat right here, you can see that this child presented with a right cheek mass. And so just ask the referring physician to just palpate. Because if they palpate and there's a hemangioma, now this is submucosal, so this is not going to be on the skin surface. But if you ask them to palpate, you're going to see a soft, pliable mass. And if the referring physician confirms that, that helps you have more confidence in your diagnosis that you are dealing with a hemangioma. If they came back and said it's rock solid and it's really, really firm and it's been growing really, really fast, then you really are thinking more about a rhabdomyosarcoma. But again, this imaging finding is not really consistent with the rhabdomyosarcoma. And I would venture to guess that in the majority of cases, when you see something like this, you're going to have a soft, pliable mass. Another example here, notice how it's high signal on T2. I'm going to emphasize this more and more, and you'll see later on why that's important. So again, you're just going to have to bear with me. But here you see this large high T2 signal mass involving the left parotid gland. We can see the multiple flow voids extending into the parotid gland. This is the lesion on the flare sequence, and this is the bright blood sequence. So what this, again, demonstrates here is the increased flow. So again, two reasons for having increased flow: the multiple flow voids, the high vasculature, and the diffuse enhancement. So again, I'm beating you over the head right here. You'll just have to forgive me. I'm an old man right now. I'm not as young as I used to be when I was everyone else's age here. but you can see the high T2 signal mass lobulated with flow voids. Now, as I mentioned before, there's a hemangioma that has a proliferative phase. And what we talked about earlier is that when you have these flow voids, there's a proliferative phase. But on the other hand, see if someone put something in the chat, hopefully it's okay. When it's in the involuting phase, what ends up happening is in the involuting phase, the tumor goes away, or I should say the lesion goes away, and then you lose the flow voids. So an involution of a hemangioma does not mean it's gone. Rather, what ends up happening is that hemangioma turns into this fibrofatty tissue. So here's a child that had an infantile hemangioma. It was rapidly growing, and then it eventually went away. And if you look real closely, you can see this little ghost here of this small little stain right here, small little capillary stain, and that means that it hasn't fully gone away. But on the other hand, it's much better than it used to be. So one thing that we can do is that if we do have a patient that comes in and they're worried about a hemangioma, if we see an area where clinically they know it's a hemangioma, and we look at this and we see the diffuse enhancement, but we do not see the flow voids, then that is indicative that the hemangioma is in the involuting phase. Now, if you just saw this de novo on a contrast-enhanced T1 weighted image in a child, then you could not exclude other pathologies. But on the other hand, if you know that it's a hemangioma and you see the absence of the flow voids, again, that tells you it's in the involuting phase. So what we've done so far is that we've spent a fair amount of time going over vascular tumors, and we know that this vascular tumor is formed by endothelial proliferation. And the main thing that we talked about were the hemangiomas, and we talked about congenital and infantile hemangiomas. Now what we're going to do is that we're going to talk about the vascular malformations. And what I'm going to do is I'm going to present to you the Olympic rings approach, if you will, to vascular malformations. So when we look at the vascular malformation, there's lymphatic, there's capillary, there's arterial, and venous. And again, I emphasize that you have to know the benchmarks, the indicators of the hemangiomas. And once you understand this, this will help us identify these vascular malformations. So when we talk about vascular malformations, as I said, there's capillary, there's lymphatic, there's arterial, and venous. So let's go ahead and start with the capillary vascular malformations. So when we talk about the capillary mass malformations, this is typically a clinical diagnosis. And I think we all know this because in patients typically have birthmarks. Now, being Indian, in India at least, or at least when I interact with my people of similar diaspora, we don't nearly see, or I don't nearly see as many capillary malformations as I do in Caucasians and fair skins. Maybe it's just they're hidden at times. But in general, especially in the Western world, we do tend to see what we refer to as these port wine stains. Now, these port wine stains can be local or extensive. Oftentimes, they're associated in the V1 and the V2 distribution. Now, when you have these capillary malformations, they are associated with Sturge-Weber. And despite the fact that we can see the staining, these are low-flow vascular malformations that typically do not need to be treated. So here's a classic clinical example of a vascular malformation. And for those of you that are of my vintage, if you will, when I grew up, this was the most famous capillary malformation. And for those of you that grew up in the Cold War, many of you probably weren't even born yet, so I just told my age. But this was the Gorbachev, of Mikhail Gorbachev, and this was always the famous capillary malformation. Now, as I mentioned before, we don't typically image capillary malformations. Why? Because they're typically located in the skin. But on the other hand, I would suggest that if you understand what a capillary malformation looks like on imaging, this will help us better understand the various other vascular malformations that we're going to talk about in just a few minutes. So as I mentioned before, these capillary malformations, this is a contrast-enhanced T1 weighted image. You can see the abnormal enhancement, and you can see this linear interstitial enhancement. And if you look real closely in the subcutaneous fat on T2, again, we can see these small little focal areas of increased T2 signal. But the main thing that I want to emphasize right now is this linear thin enhancement below the skin surface that is suggestive, that is, I should say, characteristic of a capillary malformation. But the bottom line is you just don't have to image these lesions. So the next malformation is going to be the lymphatic malformation. Now, the lymphatic malformation is sort of where you get into what we refer to as that nomenclature nightmare. So when I grew up, okay, there were so many names for that. There was, the typical name was a cystic hygroma. Then we used to call them lymphangiomas. That was another name for this. And that's really why the Mulliken-Glowacki classification was so helpful, because now we refer to these lesions as lymphatic malformations. 75% occur in the head and neck, and like with anything else, they have identified an associated mutation, which is the PIK3C1 mutation. Again, I can remember this on this slide. I think if you ask me by the end of the talk, I probably won't remember that. So, but you guys are smarter than me. You'll probably remember it, but I'll probably forget it. Now, clinically, these can present as a subcutaneous mass or a submucosal mass, subcutaneous or submucosal. And the skin can either be healthy, or sometimes what they claim is because this is a vascular malformation, it can affect the lymphatics. And sometimes the lymphatics can result in small little benign vesicles. Now, I'm not talking about the vesicles associated with Ramsay Hunt, but rather I'm talking about small little cystic vesicles in the skin. And overall, I think that's pretty rare, because at least the majority of vascular malformations or lymphatic malformations that I image, tend to be subcutaneous. So if they're there, they're there, but this is at least what's in the literature. Now, the lymphatic malformations have been subdivided into microcystic, macrocystic, and mixed. Now, initially, the microcystic really is a microscopic diagnosis, but again, we can occasionally see macrocystic macrocystic lymphatic malformations. I'll show you an example in a little while. And these are low flow lesions as well, too. So when we start looking at these lymphatic malformations, these are the typical findings. So on a non-contrast, or I should say a contrast-enhanced CT, we can see that there's no enhancement. Now, this area right here is just the submandibular gland. That's been displaced posteriorly. So if you draw a line down the middle, compare the right side to the left side, here's the normal submandibular gland on the left, and there's the submandibular gland, but notice how there's no enhancement. Now, this is the same patient on an axial T2 weighted images. We can see the characteristic findings. I'm going to emphasize that finding now. Remember, hemangiomas were also high T2 signal, just like lymphatic malformations. But what I want to point out here is notice the multiple septations. So there are no flow voids here. Remember, hemangiomas had multiple flow voids. There are no flow voids here whatsoever. And what we see here are these septations. So if you will, we could subclassify this as a macrocystic form of a lymphatic malformation. Now, because there's no enhancement, right? There's no diffuse enhancement like we saw in a hemangioma. And when we look at the T2 weighted images, just like in hemangioma, it was high signal. But notice how there's no enhancement and no flow voids. This indicates that this is a low flow lesion. So part of what we do in radiology is not only come up with the correct diagnosis, but we play an incredibly important role in triage. Because sometimes if you are working with, despite experienced clinicians, they may not be sure how to classify these. So our role is to say that it's a lymphatic malformation. There are multiple cysts, so it's macrocystic. There are no flow voids. And when you say this, you say it's a low flow lesion, and then these lesions are typically treated with some percutaneous treatment. And I've just illustrated a case of sclerotherapy. I won't get into the treatments because there's so many options right now, and it's really best addressed by an interventionist. But really, I think an important role that we have is to make sure that we properly assign the correct diagnosis and then say that it's low flow, and then they can be treated appropriately. So the next lesion, the next Olympic ring, if you will, are the venous malformations. Now, the venous malformations are the most common systemic vascular malformations. They're associated with abnormal veins, and oftentimes they'll present with this bluish skin lesion. they can become symptomatic in older children. Oftentimes, that's when they present. Now, again, unlike the hemangiomas and the vascular tumors, they can enlarge and become symptomatic not because there's rapid endothelial turnover, but it's just as you grow, these lesions can if you will, almost stretch, and they can enlarge as we grow into adulthood. So this is the classical appearance of a bluish lesion right here involving the tongue. And this is what we see on a T, in this case, this is a contrast enhanced T1 weighted image. Now, the thing about vascular malformations is, what are the imaging findings? The imaging findings, first of all, is that these lesions tend to be intramuscular, and they can actually enlarge when you sometimes do different maneuvers. So for instance, if you increased your intraoral pressure, or if you held your breath, you can actually get these lesions to enlarge. So clinically, they can be obvious. But when you see something like this, that's high signal on T2 weighted image, this is how you can typically see a vascular malformation. And this is another example here demonstrating the intramuscular location. This really is a common area to see it. This is a vascular malformation involving the masseter muscle. Now, if you look at these two on its own, it would be really hard, especially the lesion involving the tongue, to suggest that this is a vascular malformation. But I was just overseas last week, and one of my ENT surgeons called me, and when they see these lesions, they can look in there, they can see a soft, pliable mass. They don't see the rock solid mass that you do with a tumor. So oftentimes they're asking us and say, I see something that really doesn't look like a tumor. It could be a vascular malformation. And one of the imaging findings that leads us to that diagnosis is that these venous malformations, one of the characteristics is that they are intramuscular. And I do want to emphasize that within the tongue, and especially within the masseter muscle, are common locations. The other thing, too, is that if you did ask the patient of Valsalva, you can actually get these lesions to enlarge. Or if you actually laid the patient on their left side, again, there's venous pooling, those things can enlarge. So I talked about one of the primary locations for venous malformations, and those are intramuscular. The second thing is they can have multiple phlebolytes. So here's an example, a classical example of a venous malformation that shows the two characteristic features. Here we have this abnormality involving the muscle, so it's intramuscular, and we can see the phlebolytes. So if I draw a line down the middle, compare the left side to the right side, here's a normal temporalis muscle on the right. And here on the left side, you can see that temporalis muscle is enlarged, and we can see the multiple phlebolytes. Here's an example clinically of a patient that has a venous malformation. And then when we look on imaging, we can see the high T2 signal here involving a muscle. And then we see very nicely here a large, well-rounded phlebolith involving that muscle. Now, when you do dynamic imaging for venous malformations, they do enhance, but they have delayed enhancement. So if you look at this image with a leap of faith here, you can see the diffuse high signal involving the artery, but do you see the lesion? So the lesion is actually on the left-hand side. So when I sort of step through these images through this dynamic sequence, now we can see if mass would have enhancement. This is still a low flow lesion. So notice how there's no large when we evolve in where it occurs. We can see the high signal here on T2 weighted images. We can see the diffuse contrast enhancement. But again, notice there are no flow voids. Remember in hemangiomas, we saw that there was a mass with flow voids, no flow voids. So as a result, again, these patients can be treated with sclerotherapy as seen here. So when it's lymphatic malformation, which basically look like a water balloon, if you will, those two characteristic findings are intramuscular. You'll see the delayed enhancement, and then you can see those small little phlebolyts. So those are malformations is, again, as I've, if you will, gotten older. Wait, I'm not older. Remember, radiologists, we don't get older, we get more experienced. So now that I've become more experienced, what I have seen is that we have better classified, or we've changed the name, or maybe it's just a better understanding. But some of the things that we used to call, again, that nomenclature nightmare that we talked about are now being classified as venous malformations. So here's an example of something in the orbit. We can see multiple calcifications. We used to call this cavernous hemangiomas, but even when you look at the contrast-enhanced T1 weighted image in a different patient, we can actually see an incomplete enhancement. And this was actually probably a small little area of clot right here in a venous malformation, or a venous malformation. So we don't call these cavernous hemangiomas, we call these venous malformations. Similarly, in the temporal bone, oftentimes here at the geniculate ganglion, we used to call these hemangiomas involving the facial nerve, and you can have this diffuse enhancement. We now refer to these as facial nerve hemangiomas. And this is something that, excuse me, sorry, we now refer to these as facial nerve venous malformations. Sorry about that. And here's an example that, again, I grew up with on the CT scan. You would see in the spine these very, very prominent thick trabeculations involving the vertebral bodies. When we look at the non-contrast T1 weighted images, we can see high T1 signal, and there on the, so we used to call these hemangiomas, but especially when we see this trabecular pattern, but now we end up calling these venous malformations. So again, what we have done is we've consolidated this a little bit more, but realize these other things that we used to call hemangiomas incorrectly in other parts of the body are now correctly classified as venous malformations. So the fourth malformation that we'll talk about are the arterial malformations. So if you look at this, you're going to say, aha, this is an arteriovenous malformation. But in actuality, when you look at the true classifications of vascular malformations, the arterial malformation is an AV fistula, correct? So this was actually a patient that presented with right-sided pulsatile tinnitus. I just saw this case about 4 years ago. And then the presented with pulsatile tinnitus, we did a CT scan, and lo and behold, we see all these enlarged dilated vessels involving the right side of the neck. So when the interventional neuroradiologist did their angiogram, we can see dilatation here of the internal maxillary artery. And what they found was a direct fistulous communication at the level of the internal maxillary artery, then going directly into tributaries of the facial vein, and eventually that leading into the retromandibular vein. So this is a true AV fistula. Another example here of arteriovenous fistula is we typically see a CC fistula. So here we can see in the right cavernous sinus, we can see diffuse enlargement and enhancement of the cavernous sinus compared to the left. And here, when we look at the superior ophthalmic vein right here, we can see it's enlarged. We refer to this as arterialization. And when we do a CT angiogram here, we can see this diffuse enlargement here of the right superior ophthalmic vein. Now, we know when you have a CC fistula, they can be post-traumatic. So we all know about that. Now, on the other hand, you can have some congenital types of AV fistulas. And if you do, this can be seen in an HHT, and it can be seen in other various systemic disorders. And there are various genetic malformations. So when we do talk about AV fistulas, we all know that they can be post-traumatic. Probably the most common thing I see are post-traumatic, but just realize some of these can be congenital, and if they are associated with these genetic malformations. So what we've done so far is that we've talked about the vascular malformations. We talked about capillary. Remember how to remember capillary. Remember the port wine stain. Remember Mikhail Gorbachev, and you got it. If you don't know who Gorbachev is, go read Wikipedia. Okay, it's an important part of our world history. We talked about lymphatic malformations. How to remember this? We can remember that this is a water bag, if you will. We talked about direct AV fistulas, and then we talked about the venous malformations. And what were the characteristics of venous malformations? They were intramuscular, and they were phlebolyts. Those are the two things. So these are the way that if life was perfect, we would only have these four vascular malformations. But in actuality, what happens is that these malformations can occur to talk about the easiest one first. And this is something that we all see together. So if you combine your artery and your venous abnormalities, then you can come up with the classic arteriovenous malformation. So this is an example of an arteriovenous malformation involving the floor of the mouth. And what we see here are multiple dilated vessels involving the floor of the mouth. Now, one thing that you have to ask yourself is, if you see something like this, how do you know that this is actually an arteriovenous malformation as we see here? And how do you know it's not a vascular tumor? So this is the following, is that if this was a vascular tumor, let me go back to hemangiomas, because that was our benchmark. With hemangioma, a soft tissue abnormality. Why do you end up having this atrophy here involving the muscle? There's no soft tissue mass right here. The reason is what is an arteriovenous malformation? In capillaries, you have nothing that connects the arteries and the veins. What do capillaries do? They act as a way for nutrients to actually leave and extend from the arteries and the veins to extend into the soft tissue. So they allow these nutrients to actually nourish the surrounding soft tissues. So if you don't have capillaries, then the surrounding soft tissues cannot have the nutrients they need to grow, and they end up getting smaller and smaller and smaller. They end up retracting. So that's why when you have AV malformations involving the brain, you end up having gliosis and atrophy, and it's vascular mouth. Another example here, a very, very large arteriovenous malformation involving the right neck. This actually involved the larynx, and we can see here the large dilatation of the internal jugular vein. This is high flow. So when we say it's high flow, then the way that what's done here is that our interventional neuroradiologists end up doing an angiogram. This was pre-embolization, demonstrating this large arteriovenous malformation. And this was post-embolization. We can see the reduction in flow. So if we as a radiologist say it's high flow vascular malformation, then these patients are treated typically with some type of endovascular treatment. And the majority, based on the venous flow, they can potentially do a combined transvenous approach as well. So you have a combined lymphatic and a venous malformation, then this is what you end up having with what we can call a lymphatic venous, or you can flip it around, a veno-lymphatic malformation. So this is a combination lymphatic and venous. Now, how can we identify these lesions? Again, in order to do this, you have to remember the components of what is lymphatic and what is venous. So when we look at the lymphatic has a lymphatic component, what we end up doing is that we end up looking for the high T2 signal. So remember, the lymphatic lesion was like a water balloon. It contained fluid. So in this particular case, we can see the high T2 signal, and that tells us there is very likely a lymphatic component. Now, what about the venous component? How did we identify that this was a venous component? What were the two things? Two was phlebolyts. So when we look at this lesion right here, let's draw a line down the middle, compare the right side to the left side. Notice the normal appearance of the masseter muscle on the left, and on the right-hand side, we can see this mass is actually involving the masseter muscle. So this is involving or potentially arising from the masseter muscle. So that tells us it's intramuscular. What was the second component? It was the phlebolith. And when we look here, we see this phlebolith right here that's located within this mass. Do we see the serpiginous flow voids that we saw in an arteriovenous malformation? No. Do we see the flow voids that we see in a hemangioma? No. You can argue and say, well, if I just saw this, it could be a hemangioma in a child, but what's absent? What's absent are the multiple flow voids, and hemangiomas, the infantile, the congenital, typically don't have phleboliths. So once you understand the characteristic imaging findings, then we can make the diagnosis of a lymphatic venous malformation, or you can flip it around and say veno-lymphatic. Either one of those is fine. This was the husband of one of our techs. He presented with a mass involving the right cheek, and I remember this very well. The tech would say, yeah, my husband's had this blue discoloration. When he sleeps on the right side, that gets larger and larger. It's not really moving at all, but it just gets kind of bigger. And when we looked at this, what we saw was this mass right here. We can see it's high T2 signal. In this case, it's actually involving the buccal space. When we look at the little lower on the T2 weighted images, we can see the multiple phleboliths. One here is seen by the yellow arrow. And then when we look at the non-contrast T1 weighted images and with contrast, we can see this mass is actually involving the buccinator muscle as well. So now all of a sudden we've got the water balloons here that are indicative of the lymphatic component. We can see the phleboliths, which are indicative of the venous component, and then we can see involvement. Here's the normal buccinator muscle on the left side. Here we can see that involvement on the right side. So now we have the two components for venous. So when we saw this, we can say, I just told him, hey, your husband probably has a veno-lymphatic malformation. It's a not high flow lesion, it's a low flow lesion. So if they want to, then the best treatment would be sclerotherapy. In this case, they opted not to do anything. So another example here of a huge veno-lymphatic malformation involving the chin of a child. And again, this was treated with sclerotherapy. So if we continue our Olympic rings approach to this, we can now look at another complex vascular malformation that we can make the diagnosis. So if you combine a capillary lymphatic malformation, if you just look at this and you look at these components, you can, in your mind's eye now, figure out what a capillary lymphatic malformation is going to look at. So let's talk with lymphatic. What's it's going to have? Well, it's going to contain fluid, right? It's going to be a big blown up water balloon. So that's going to be one of the characteristics. What about capillary? Well, we don't image capillaries, but remember those interstices, remember those linear areas of enhancement. So that's what we look at when we're trying to identify a capillary lymphatic malformation. So here's a lesion involving the left parotid gland. Now, one of the first cases I showed was a hemangioma involving the parotid gland. So let's draw a line down the middle, compare the. So one can look at this, and on the first glance, you can say, my gosh, is it a tumor? Well, it could be a tumor, but when you palpate this, it was very soft and pliable. So that would make a tumor very unlikely because it would be rock hard. Second of all was could it be a hemangioma? Because that's common in a kid, right? But when you look at it, you can see the high T2 signal. You can actually see some septations, but what do you not see? You don't see any flow voids at all. So that makes a hemangioma very unlikely. But on the other hand, it makes a lymphatic malformation more likely because it has high T2 signal. Now, here's a non-contrast T1 weighted image, and here's the contrast-enhanced T1 weighted image. Again, if this was a hemangioma, this should homogeneously enhance avidly, and we'd see the flow voids. But instead, we don't see the enhancement. Instead, what we see are these linear areas of enhancement along the septations within this abnormality. So this is characteristic of the capillary component. So if you can see the lymphatic component right here, which is that big water balloon, and then once we give contrast, we can see this linear enhancement. Well, wow, now we can make the diagnosis of a capillary lymphatic malformation or lymphatic capillary malformation. You can flip this around any way you want to, but that's the characteristic finding of this particular abnormality. Another lesion here, you look at this and you say, wow, this looks like a mess. So first of all, is this a tumor? Well, it's unusual because, again, this can be easily seen by our referring physicians. In fact, if with a leap of faith, you can even suggest right here some abnormality involving the skin. So it's quite possible this could represent that skin thickening or maybe some tiny vesicles. But when you look at this, what we see here is multiple areas of low attenuation. So this is involving the submandibular space, this is involving the tonsil, it's involving the floor of the mouth, and it's involving the left side of the neck. Now, if this was an infection, the patient should be sick as stink, right? But they're not. They've been walking around. So that suggests the lymphatic component. And then once we give contrast, what we can see here are these multiple linear areas of enhancement within the abnormality. So again, you have the lymphatic component, which is the fluid, and then these linear areas of enhancement, which are the capillary components. So again, we can make the diagnosis here of a capillary lymphatic or lymphatic capillary malformation. That's how you can use the knowledge, and you can use this Olympic rings approach. Now, occasionally what can happen is that you can have lesions that can involve three of these components. So you can have capillary lymphatic venous, and then you refer to these as a mixed vascular malformation. So this can either be with 3 rings or you can actually have 4 rings. So how do we use this to understand and make the diagnosis of a mixed vascular malformation? So here's a patient that has this diffuse abnormality on T2 weighted images. Notice the high signal right here. It's everywhere, right? So that tells us there's a lymphatic component. Now, when you look at this, there are a couple of questions that you have to ask yourself. First of all, is this a big tumor? Okay. If this was a big tumor, this would be clinically obvious. There's no way that they would miss this tumor. The second thing that can kind of look like this on the non-contrast T1 weighted images is that I have seen multiple cases of neurothecosis, or more commonly neurofibromatosis, present this way. But on the other hand, clinically, this would be obvious for neurofibromatosis. So if you just look this on alone, you really couldn't make the diagnosis. But if they're telling you, they say, well, I think this patient has a vascular malformation, I want to know what it is and how it can be treated. The way that we would analyze this is that we would say this is increased T2 signal. So there's our fluid component, there's our lymphatic component. When we look at this on the non-contrast T1 weighted images, we can see that it's involving multiple spaces. And when it enhances, we can see all of this enhancement right here. So we can see that it's involving various muscles. So that probably tells us there's a venous component. We can see these areas of linear enhancement. So that tells us there's a capillary component. And lo and behold, when we look at our CT scan, we can see multiple phlebolyts. So when you see the phlebolyts and the intramuscular component, we know it's venous. When we see the high T2 signal component, we know it's lymphatic. Lymphatic also involves multiple spaces often. Again, that's supportive of a lymphatic component. And when we see this serpiginous linear enhancement like this, this tells us that it's likely a capillary component. So when you look at this, do you see flow voids? No, not at all. And we don't see that robust enhancement. So what we can confidently tell our physicians that, yes, number one, this is a vascular malformation. Number two, it's a mixed vascular malformation. And number three, there is no high flow component. So this is a low flow lesion. And the best way to treat this probably would be to some type of sclerotherapy. If they wanted to do a resection, they could try, but obviously they're not going to get a very good result because it's just so extensive. So in summary, what we've done over the last 15 minutes or so is that we looked at vascular lesions of the head and neck. And what I tried to give you was that simplified approach. So just to finish up is that we talked about the vascular tumors. Remember, these are defined as endothelial proliferations, and we specifically talked about hemangioma. These were lobulated lesions enhanced with contrast and had multiple flow voids. Then we talked about the vascular malformations. Remember, the capillary had these linear interstitial enhancement, the port wine stains. The lymphatic malformations were like the water balloons with sometimes septations that did not enhance. The arterial were the ones that were high flow, and the classic one was an AV fistula. And then the venous were intramuscular and calcifications. And if you remember these, and if you specifically remember the characteristic findings of this, then you can take this and you can win your own gold medal right here with the Olympic rings, because now you can make these more sophisticated diagnoses based on the combination of the imaging findings. So thank you very much for your attention. It's again an honor to be here. It's always wonderful to lecture for REF. And I've got maybe about 8 minutes to answer any questions. Again, thank you very much for the opportunity.
Yeah, thank you, Dr. Mukherjee, for that wonderful session. Your expertise seriously brought clarity to a complex topic, and as Dr. Bharadwaj just said in the chat box, you made a nightmare to a fairy tale. Uh, that was a concise and an apt uh, end to the session. We have almost 30 questions, and now I'll be really hard pressed to pick and choose which ones I can. Maybe I can fit in a few in the next 5 minutes. So
Okay.
yeah, uh, the first question is, how do we differentiate cystic hygroma versus a branchial cleft cyst?
Yeah, that's a great question. So let me see if I can bring that up real quick. I'll do this with you. I will I probably won't be able to answer every question, but if I do, I'll try to give a thoughtful answer. How about that? So instead of trying to race through everything, I'll try to give a thoughtful answer. And ironically, I just happened to put a brand new talk together, and maybe I'll give this to you guys one day if you want to. But it's more of a teaching. It's a missed case diagnosis where I actually show some of my misses. But what I wanted to do was that this was a case not of a branchial cleft cyst, but this was a 50-year-old that had a right neck mass. Don't call this a branchial cleft cyst. Don't call this a lymphatic malformation in an adult. And if you look real closely, we can see this thick enhancement right here with the cystic area. Now, when this, on the other hand, is a case of a lymphatic or a second branchial cleft cyst. So a second branchial cleft cyst tends to be well defined. They are located just anterior to the undersurface of the right sternocleidomastoid muscle. And if they can become infected, occasionally they can enhance. So this was an atypical case of a second branchial cleft cyst. In an adult, you should still call that a metastatic lymph node. It's better to be wrong in that situation as opposed to miss a squamous cell carcinoma. But to answer your question specifically, they have this characteristic location just deep to the sternocleidomastoid muscle, and they tend to be well defined without internal enhancement.
Yeah, thank you, sir. And I was already looking for dates for that session in maybe December or January. We cannot lose out on the opportunity.
The next talk is supposed to be brachial plexus. I already told Akshay wanted me to give my updated talk on brachial plexus. So you guys can choose which one to do next. Either is fine with me.
Sure, sure. Or both maybe. We are getting greedier day by day. So the next question is, how do we differentiate a hemangioma in involuting phase from a low flow or a venous malformation? Like,
Yeah, that's a wonderful case. So I think that's a wonderful question. I think it could be a little bit hard in the sense that the hemangiomas will, first of all, let me put it this way. The hemangiomas, the referring physicians probably already know there's a hemangioma. So if the patient knows that there's a hemangioma, oftentimes they want to know if it's going to grow or whether it's going to involute. Because you can imagine if you were a child, the parent of someone like this, and you saw this, you're like, is it going to get worse or is it not going to get worse? So oftentimes the diagnosis is already known. I think the second thing is that probably the way, as was mentioned, that hemangiomas are not necessarily typically intramuscular. So a lot of these hemangiomas that I showed are actually in the soft tissue. So notice the sternocleidomastoid muscle here, and this is outside. Hemangiomas, I'm sure, can be intramuscular, but the way that I would probably sum up is that if you saw a lesion and it was within the muscle and you saw the phlebolytics, especially the phlebolytics in these cases, that's how I would help differentiate a venous malformation versus an involuting hemangioma.
okay, thank you, sir. Uh, then next question is, is it a like for differentiating a high flow from a low flow?
Yeah, that's a great question, fellowship, and I think a lot of these lesions can be initially suggested to be a vascular malformation on ultrasound. The challenge with ultrasound is very tech dependent, and so often indicated pediatric neuroradiology group with pediatric techs, they can say that it's a high flow or there's an abnormality, but they may not be able to characterize it. So, but on the other hand, I think ultrasound is a great initial way to especially help differentiate tumor versus non-tumor, especially if it's pliable. But I think if you are evaluating this, it's really helpful to give contrast because it's going to help you, number one, to see whether it's enhancing. The second thing it's that will help you identify better the extent of the lesion as well too, and identify the various flow voids. So for that initial evaluation, I always like to give contrast because of those specific areas, and that'll help you again characterization, capillary. If there's a capillary component, it'll help you look for that interstitial enhancement, and it's going to increase the conspicuity of the flow voids.
Yes, thank you, sir. I think I'll leave you with some time in hand because there are plenty of questions and I find it difficult to choose which of them. Anyways, it was just lovely to have you on this platform, and we are all already excited for the future, the next lecture that you're going to take. It was just lovely, and thanks for taking your time out. If there was an Olympics in radiology, I'm sure you would bag most of the gold medals. That was lovely. We all loved the Olympic rings approach as well. So thank you, sir.